Glick's chapter 15 deals with health problems, disabilities, death and dying, and access to care, the roles of medical social workers. In this particular day and age, with the controversy of the Affordable Care Act, or Obamacare, as it is referred to more popularly, this particular chapter is of quite some importance because this really does talk about the kinds of issues and concerns that have led to the need to develop a national health care insurance program of some time. I just want to briefly point out to you, as far as health care and national health insurance is concerned, that this is a topic that certainly didn't start with President Obama, but really goes back quite a long time in our history. And I can tell you that even 100 years ago, there was some discussion about health care in the Social Security Administration, in Social Security Act in 1935. The legislation associated with it originally had a national health care program included in it, and it was dumped from that program because of the protestations of the American Medical Association as well as other organizations. In the 1940s, I believe, President Truman tried to, or pushed for, at least forward towards a national health insurance program that didn't get anywhere. President Nixon, Presidents Kennedy and Johnson began to move in that direction with the introduction of the Medicare and Medicaid programs that we talked about in the chapter on the elderly, and also other chapters as well. President Nixon proposed some national health care legislation in the 1970s to expand insurance programs to others, and got nowhere. In the early years of the Clinton administration, Hillary Clinton, in fact, found herself vastly unpopular with Americans as she chaired a committee that had intentions of establishing what would have been a true national health insurance program, that is a single payer health insurance program where essentially the government would provide the health insurance and extend to everyone in the nation. That was also again campaigned against strongly by the American Medical Association, and now as President Obama's program really is a compromise on that, and is still inadequate in terms of providing health care for everyone, but it is a step in that direction at least to provide more universal health care coverage in a very wealthy nation. We think that we have the best health care in the world, and as Glicken points out, the reality is not only do we spend much more for health care than any other nation, but because of poverty, race, gender, and ethnicity issues, many people receive marginal or no health care at all, and this in one of the richest nations in the world. The United States has a higher infant mortality rate and a shorter longevity rate, that is, a shorter lifespan, than almost any other developed country that includes Australia, Canada, England, France, Germany, Israel, Italy, and Spain. We have lower infant mortality rates and shorter lifespans on average than individuals that live in those nations. Now stop and consider the fact that the critics of national health insurance often tell you about how long the waits are and how terrible the care is, how poor the quality of care is in places where a socialized medical system such as Canada and England and France exist. And yet look at this. We have a higher infant mortality rate. We have a shorter lifespan than individuals that live in those nations. How can it be that things are so terrible with the healthcare system in those nations when our results are poorer? The World Health Organization reports for the year 2000 that we spent a far greater portion of the gross domestic product of the United States on healthcare than any other country, but then goes on to say that it's distressing to learn that despite being the world's richest country, the World Health Organization ranked the overall performance of the American healthcare system at 37th among the 191 UN member countries, behind, very like third world countries. Actually, some of them were doing better. Why do we have these statistics? For the most part, The medical care system doesn't work well because so many people are not a part of it. They don't have access to health care. They don't have insurance. Poverty causes people to wait until their medical conditions are so serious, and then they use emergency rooms, which tends to be very expensive and costly for medical attention. They don't have access to the kind of care that individuals with private insurance might have that could prevent them from having to go to emergency rooms. And because of the different ways, and we'll be talking about this in future slides here, that culture, gender, and race are dealt with in the medical care system, there's a distrust of the medical care system, and so oftentimes individuals of minority groups are very reluctant to seek out help. While there's been some improvements in healthcare for African Americans over the last 3 decades, they still have twice the mortality rate of Caucasian Americans and have a significantly shorter life expectancy. 6 years, this says 6 years or less. In other words, the life expectancy, actually 6 years or more, I think is what it is, of less life expectancy, the shorter lifespan by 6 years on average. And this is similar, to the kinds of differences between black and white Americans and cares in other areas as well. It's not just in healthcare, of course, also in education and in other areas. African Americans are shown to receive fewer specific surgeries for cardiac problems, kidney transplants, and other high-cost medical procedures that prolong life. They're less likely to have those procedures even if they have insurance. About 25% of all African Americans in the United States and over a third of all Hispanics have no health insurance at all. And the textbook talks about the Tuskegee experiment, and I'm not going to go into details of that, but it was a non-consensual experiment where medical professionals treated African Americans really as guinea pigs, essentially, and so this kind of thing back, and this is some years ago, but it is this kind of a history really that lingers and really creates a lot of distrust in the American medical system among those individuals who are in minority groups. African Americans are overrepresented in populations at high risk for developing mental illness. Primarily the homeless, prisoners, and children in foster care, where the need for mental health treatment is generally higher. They're more likely than whites to receive mental health treatment for the first time in emergency rooms, again, having to go to the emergency room to get the care they need, or in psychiatric hospitals where they're contained because they delay seeking treatment, and so their symptoms become worse before they actually go to seek any help. The mental illness rates among Hispanics are about equal to those of whites, but young Hispanics have higher rates of depression, anxiety disorders, and suicide. And it is those who are born in the United States, those Hispanics born in the U.S., that are more likely to suffer from mental illness than those born in Mexico or those living in Puerto Rico. American Indians and Alaska Natives also, because of their isolated kind of rural settings, oftentimes have very severely limited mental health treatment options available to them. We see this even because we service some of the outlying communities in the Bering Sea, and trying to arrange for services sometimes that are commonly available even in the smaller communities on the along the road system, for instance. I mean, it's very difficult to get even just kind of typical common mental health resources to those individuals. So the suicide rate among American Indians and indigenous Alaskans is as much as 50% higher than the general U.S. population, and I think that's really an underestimate. As I mentioned in a previous lecture, that I've read that the rate of suicide among young Alaska Native males is 5 times that of the rate in among individuals in the lower 48. Race is one thing, gender is another issue as far as healthcare is concerned. Men outrank women in all the 15 leading causes of death except for Alzheimer's disease, and are at least twice as high as women's rate for suicide, homicide, and cirrhosis of the liver. They're more likely to be heavy drinkers and to engage in risk-taking behaviors. Women are twice as likely as men to visit doctors, and are more likely to look at prevention programs than men are. Men are less likely to schedule checkups or to follow up when symptoms arrive. Um, it is sort of a macho thing that men don't turn to physicians and don't fuss over their general health as much as females do, and of course that's to their own detriment, and as a result sometimes they often wind up self-medicating their own psychological problems, and so will have higher problems with drinking and drugs. Given this, it's not surprising to find that women outlive men an average of 6 or 7 years. Um, and cancers related to smoking, things like that, prostate cancer, those kinds of things also are high in men. 3 times as many men suffer heart attacks before the age of 65 than do women, and nearly 3 in 4 coronary artery bypasses in the mid 1990s were performed on men. Bladder cancer 5 times more often than in women. Nearly 95% of all driving while intoxicated cases involve men. You can see here that and that really to be male is hazardous for your health. Suicide for white men is 9.4%. I'm sorry, 9.4 per 100,000 as compared to 2.9 for white women. And that rate increased, as you can see, over the next couple of decades and has continued to increase into the early 2000s. But still, suicide rates for black and Latino men were almost 6 times the rate of suicide for black and Latino women. So what is it that explains this? In all likelihood, this has a lot to do with socialization into traditional masculine roles, and this is something that has been something that I've touched on in previous lectures in this class. There is a need for men to maintain this strong image of masculinity, and this really leads to a lot of these particular problems. They don't go to doctors to get checkups. They don't feel comfortable in the patient role, to being dependent upon an expert. Men tend to want to take care of their problems themselves or to wish things away. They don't like going to psychotherapy. They're much less likely to sit down and really talk about their problems with anybody. The assumption is really, boys don't talk, boys are tough, boys don't cry, those kinds of things, and so it really kind of sets males up to have this particular kind of attitude that is really very debilitating to them as their life goes on. Gender role socialization being as many as 3/4 of the 7-year difference in the ages, the lifespans of men and women is believed by at least one study to be the cause for that. I have read other studies as far as men and women are concerned that suggest that men are approved for medical procedures, serious, costly medical procedures, more frequently than women are by insurance companies. The implication of the studies that I read was that there was an inequality in that it wasn't because men needed it more often, but that men were somehow provided approval by insurance companies more frequently than women were for similar procedures. Turning to the topic of HIV and AIDS, which is an area of concern for the social work profession, well, for everyone, but I mean it's an area of practice really for the social work profession. The National Institutes of Health report that there are more than 830,000 cases of AIDS in the United States since 1981, and almost 1 million Americans may be affected, 25% of whom are unaware of their infection. This is a growing epidemic. It's a leading killer of African American males in the 25 to 54 year age group. And African Americans are 7 times more likely than Caucasians to suffer from AIDS, and 3 times more likely than Hispanics. And as the slide suggests, anyone who practices risky behaviors such as unprotected sex, sharing drug needles or syringes, those kinds of things, is at risk to contract HIV or AIDS. And here are some of the symptoms that are experienced, sometimes months or years before the onset of AIDS itself. So lack of energy, weight loss, fevers and sweats, those kinds of things. The diagnosis of acquired immune deficiency syndrome, AIDS, is given when HIV-infected people have a T cell count that falls below a certain level that that is defined, that is medically defined, so to speak, and the opportunistic infections that are common in people with AIDS includes many of the things on that particular list, the symptoms of those infections that you can see there that AIDS patients often suffer from. There are some individuals, it used to be thought that if you had HIV, that was the forerunner to AIDS, and it was only a matter of time before you would develop AIDS. But there is a small number of individuals that were first infected with HIV 10 or more years ago that have not yet developed symptoms of AIDS, and there's efforts to try to determine the causes for this that might include things like the particular peculiarities of their immune system, or do they have a less aggressive strain of AIDS that has, or that the virus that hasn't been identified? Is there genetic factors involved to protect them? These are things, of course, of great interest to the medical community. There have been a lot of criticisms over the years that there hasn't been enough, particularly given the magnitude of the epidemic, the problem, not only in the United States, it's even larger in other parts of the world, much larger in other parts of the world, that the research that has been devoted to this, the funding that has been devoted to AIDS has been pitifully, woefully inadequate, and so this continues to be a very large problem. I believe that the profession will see itself facing and working with these patients for many years to come. Social workers engage in a variety of behaviors with AIDS patients, including arranging for medical care, education, helping families cope with the anguish over the disease, working to overcome public perceptions of who gets AIDS. The popular perception had been for a long time that this is a gay disease, so to speak, and in fact, this is a disease that anyone can contract. Other disabilities is another area that social workers find themselves working in the medical field, and there are estimates that as many as 24 million Americans suffer from a severe disabling condition, and that almost 2 million more people with disabilities are homebound, and another 12 million temporarily homebound. And as mentioned earlier, with the in the unit on working with elderly adults, many of the caretakers of the disabled and elderly people are homebound themselves because of the specific dependency and the needs of the individuals that they're caring for. And so these individuals become alienated and socially quarantined from the larger society, and this leads to all sorts of emotional problems that include things like depression and loneliness and that kind of thing. The Americans with Disabilities Act was passed by Congress in 1990 to protect individuals from discrimination on the basis of their disability, unlike those individuals who had protection with race, color, gender, national origin, and those kinds of things. It was still possible up until that time for employers and others to discriminate against individuals because they were disabled. Many individuals with disabilities occupy an inferior status in society and are severely disadvantaged socially and vocationally, economically, and educationally because of the disability. And the ADA is intended to address those deficiencies. So the purpose of the Americans with Disabilities Act is intended to eliminate discrimination against the disabled and provide standards where the government actually can do something to deal with the discrimination against disabled, ensure that the federal government enforces those standards established in the Act, and use congressional authorities to enforce the 14th Amendment, that is the Equal Protection Amendment, and regulate commerce to address day-to-day discrimination faced by the disabled. Medicaid and Medicare, we've talked about a number of different times during the course of the semester. Established through the Social Security Act, but many years after the initial implementation of the Social Security Act in the mid 1960s. And Medicare is the federally funded program that offers medical care for Americans older than age 65 primarily, and also some Americans with disabilities younger than age 65. Medicaid pays for medical assistance for individuals with low incomes and resources, and also with certain disabilities. Medicaid is the largest source of funding for medical and health related services for people with limited income. It is a very vital program for those individuals who are limited in terms of their ability to provide medical care for themselves. As far as older individuals are concerned, Medicare doesn't cover all of the medical requirements of older individuals, including prescriptions. Now, this what they call the donut hole has existed, where Medicare would pay for certain prescriptions up to a certain amount, but then not pick up again above that amount until it reached catastrophic proportions, in which case then Medicare would again begin paying for the elderly's prescriptions. And so many individuals were stuck in what they call the donut hole of where it wasn't covered. And one of the things that the Affordable Care Act is intending to do, is to shrink that donut hole so that essentially adults have more reliable prescription coverage. There are other things that Medicare doesn't cover for the elderly as well, and there are supplemental plans that are available, but not all individuals can afford it, because their retirement, even with Social Security, is not very comfortable sometimes, and so they may not always be able to obtain the services they need. If the elderly have a private insurance program of their own that supplements Medicare, or that Medicare supplements, that is the kind of thing that helps people get through those years, but not everyone has that. Social workers in medical rehabilitation services work in hospitals, clinics, health maintenance organizations, rehabilitation centers, providing support services and discharge planning and supportive services for individuals who are receiving services in those facilities. They look at setting up things so that after hospital care is sufficient and worthy of the need of the individual involved, and will help with dealing with the emotional aspects, not only for the patient but also for the patient's family at time, and can help them in terms of getting applications submitted and qualifying for Medicare and Medicaid and other kinds of programs that individuals sometimes aren't aware of the benefits that they are eligible for. Terminal illness is dealt with in this chapter too, and sometimes people with terminal illnesses are not able to deal with a number of the important emotional issues, because they find individuals avoiding them rather than being there for them and supporting them, and sometimes question some of their basic belief systems. Sometimes the medical care system will make important treatment decisions without actually consulting the terminally ill patient for whatever reason, and so sometimes they can't be involved really in dealing with in planning for their own care, and so pain-killing drugs is another thing sometimes that can intrude in their ability to really participate, and also to maybe take the time to resolve relationship conflicts or things like that need to be resolved before they die. Low levels of spirituality in terminally ill patients tend to be related to end-of-life despair, and create some additional problems that can lead to more emotional difficulties as the individual faces his or her end of life. Social workers' role, according to Blundo and others, would be to really engage clients in a collaborative dialogue about their end of life, and really kind of setting aside any preconceived notions we might have about emotional difficulty. This collaborative relationship with the terminally ill patient helps the patient to reorder their own priorities and maybe spend more time with their family, and continue to grow through that process in their final days. Physicians also, are famous sometimes for being unempathetic, I think is the term that is being used here. This one study that Richmond conducted in 2000 also talks about the difference that an empathetic physician can make with patients in terms of symptoms of depression and things like this versus those who are not. For those that are left behind, bereavement is an issue, and social workers find themselves engaged with those persons as well in dealing with the loss of that significant person, because there are all sorts of things that can result from that. Now, bereavement in and of itself is of course, a very common and perhaps even could be said a healthy response to the loss of a loved one. The question is, how much does that bereavement intrude upon the survivor's ability to continue on with their life? There isn't any kind of a healthy length of time. In America we have this kind of thing about a person dies and the funeral generally is like 3 or 4 days later, and then people just kind of go back to their life. And had a relative recently die, and many members of the family gathered around the widow and stayed with her through the relative's death, and stayed there for a couple of days after the funeral, and then everybody left at one time, and there she was by herself. And perhaps that's the way it goes. I think that is probably more common than not, and so one of the things that we can do sometimes in working with bereaved families is try to determine whether or not, first of all, the bereaved individuals really want others around them, and then perhaps try to help family members to plan for that and to ensure that they remain in contact and don't kind of leave the person alone at times when they might really benefit from more interactions and things like this. There isn't any length of time. Like I said, we have this 3-day period, and we think people then just have to get on with it. And in fact, normal bereavement, healthy bereavement, can last more than a year. It is not at all unusual, and persons should not assume that an individual has a complicated bereavement or an unhealthy bereavement if they're still grieving a year or two later. Bereavement lasts as long as bereavement lasts, and we just need to provide support to the individuals that are dealing with that loss. Despite what I just told you here, there's one study that suggests that these symptoms last more than 2 months, can sometimes suggest prolonged grief, and that doesn't necessarily contradict what I just said to you. These are some symptoms and signs of ongoing grief after the loss of a loved one. We do not have to characterize this or assume that the existence of these things some months later means that the individual has got a psychological problem with the loss. Normal grief can last for any lengths of time, but here are some of the more serious kinds of things that oftentimes bereaved individuals experience. Finally, just a slide on the Healthcare Reform Bill of 2000, or the Affordable Care Act. It was passed in March of 2010, and the Supreme Court upheld most of the provisions of the Act in the year or so after that. And despite the fact that opposing politicians continued to threaten to overturn the Act, it seems pretty much as though the Affordable Care Act is established now, and it really is the first major health care legislation passed in the 45 years since the passage of Medicare and Medicaid. And it does extend health care coverage to up to 32 million people who have lacked it previously. And there are a number of different things that place new rules on insurance companies that include banning lifetime dollar limits on policies, banning coverage denials for pre-existing conditions, policy cancellations if someone gets sick, banning that, ensuring that children up to age 26, in covered insurance programs at least, that children up to age 26 can continue on their parents' policies even if they're not living at home. And here that donut hole that I was talking about, prescription coverage, closing that gap. And so these are just some of the features of the Affordable Care Act, and Again, this is far short of a national health care program that provides coverage for everyone, but it is a national health care program that health insurance program that at least begins to extend insurance and health care to a larger population of Americans. So with that, it closes the lecture for chapter 15, and let me know if there's anything you have, any questions you have lingering. I'll be happy to answer them. Thank you.